Dear colleagues, good morning, good afternoon, good evening to you who are in different places and time zones. And thank you very much for attending this important webinar, which will discuss the role of laboratories in COVID-19 pandemic response and laboratory testing issues. The world of nanotechnology, space invasion, and sophisticated weapons and missiles kneeled on the front of this small, tiny microorganism, SARS-CoV-2. The world will not be never the same, with prolonged restrictions on travel and trade, more outbreaks of other infectious diseases, market collapse, and unemployment. In addition to the acceleration of innovation on vaccine, drugs, and lab technology development. It's worth noting that after the isolation of the virus at the beginning of January of 2020, the genetic sequence was published, which greatly helped in the manufacture of test kits and their use in an urgent manner. At the beginning of the outbreak, laboratories played an important role in the diagnosis, the first cases, and to date, still testing millions of samples. During the webinar, we are going to highlight the importance of public health laboratories in COVID-19 response. We are going to discuss the available tests, molecular and serology ones, and the performance of these tests. We are going to discuss the sample management, safe handling of samples. We are going to highlight the importance of antibody-based tests as another element of biosurveillance for enabling identification of people with past exposure to the virus. We are going to describe the role of critical care tests in managing COVID-19 patients. And we are going to talk about a global situation on laboratory testing and challenges. Please join me to welcome our panel of experts, His Excellency Dr. Azmi Mahafza, Professor Azmi Mahafza, and Professor George Araj, and Dr. Erin Sorel. I will give a short bio of doctors as we are going to present their talk. So first presentation will be given by His Excellency Professor Azmi Mahafza, Professor of Department of Pathology, Microbiology, and Forensic Medicine, University of Jordan. Professor Azmi Mahafza got his PhD in microbiology and immunology from the American University of Beirut. He then did a postdoctoral fellowship training in virology at Yale University School of Medicine. Professor Mahafza has been working in the Faculty of Medicine at the University of Jordan and for about 30 years, where he served in several high-level positions. In 2016, he was appointed as the president of the University of Jordan. Furthermore, he is a member of several scientific societies and committees. His research interests include immunology, diagnosis of infectious diseases, nosocomial infections, and the epidemiology of infectious diseases. Dr. Azmi was also the former Minister of Education in Jordan. Dr. Azmi, you are welcome, and we are delighted to have you with us. And please, the floor is all yours.
Thank you very much, Dr. Tariq, and I welcome my colleagues in this webinar, and it gives me great pleasure to participate with them in this very important topic. As all of you know now, COVID-19 cases has reached more than 33 million in the world, and it has caused the death of more than 1 million people. In Jordan, the number has increased several folds in the last few weeks, and this reached 51 yesterday, but I had just a few minutes that
We cannot hear you. There is something wrong going on.
Yeah, we lost Dr. Azmi, I think.
Dr. Azmi has to come back.
Yeah.
Cause human as well as animal infections. They're polymorphic, envelope, positive sense single-stranded RNA viruses that range in size from 80 to 160 nanometers with a distinctive morphology. Their genome is the largest among all RNA viruses, and it codes 16 non-structural and 4 structural proteins and some other positive accessory proteins, making the number about 29 proteins. This is an exception probably with all RNA viruses that they have proofreading mechanisms, keeping the mutation rate relatively low, although they have 2 mechanisms of change, genetic change, mutation, and discontinuous transcription or recombination. The distinctive morphology of these viruses is shown. And Tariq, can you move the slides? Because I'm talking about the morphology of with the 2 electron microscopy and the drawing graph. Yes, that the slide before, yes. The distinctive morphology, which gives the name of the virus, a halo surrounded by a halo because of the spike protein. And the classification of the family of coronaviruses, as shown in the next slide, is family Coronaviridae, subfamily Orthocoronavirini, and there are 4 genera: alpha, beta, gamma, and delta. Human pathogens fall into the alpha coronaviruses, where we have the 229E, one of the oldest one, and the coronavirus NL63, and the beta coronavirus, which includes 5 members, the most important of which are SARS, that caused the epidemic or pandemic in 2002-2003, MERS, and the SARS coronavirus 2. Now, the genetic relatedness, coronavirus 2 or SARS coronavirus 2 is related to SARS virus, SARS coronavirus. And it has the typical genetic structure like other coronaviruses, which is shown in the next slide. Now, next slide, please, Tariq. Now, coronaviruses next. Coronaviruses can be cultured and in different cell lines, cell types. They have a latent period of about 5 to 7 hours. They can cause cytocidal as well as persistent type of infection. Cell culture is not widely utilized in the diagnosis of COVID-19, of coronavirus infection. It requires, of course, a biological safety level cabinet 3. And in the next slide, the replication of coronavirus is shown, where they bind to AC2 receptor to SARS coronavirus 2, of course. It binds to the AC2 receptor, and with the help of the transmembrane protease, serine protease, it fuses with the cell membrane. The RNA is introduced, and the first step, because it's a positive sense RNA, it can be translated directly, and the 5' end of the genome is first translated into the non-structural proteins. Then a negative sense complementary strand is synthesized, which act as a template to produce messenger RNAs from the non-translated part, as well as a template for the genome. Then when the proteins are in the second phase of transcription, messenger RNA codes for structural proteins that are produced, they assemble with the genome that have been synthesized from the negative sense template, and then at the goal, the rough endoplasmic reticulum, they acquire an envelope, and they are transported within vesicle to leave the cell, which causes, in most of the cases, the death of the cell. It's important to note here that only 5 to 10% of viral particles produced are infectious, and the others are defective interfering particles, which may interfere in diagnosis. They may give a positive result in individuals who have recovered from infection, for example. And this is very important in diagnosis. So molecular diagnosis of coronavirus relies on the detection of gene sequences that vary depending on the test, the method used, and the methods that are used are the reverse transcriptase quantitative PCR or the reverse transcription loop amplification or the clustered regular interspaced short palindromic report or technology and gene sequences. However, the reverse transcriptase is the most widely used method for diagnosis, as you know. Now, the second slide shows these methods that are utilized in diagnosis. The clinical specimens that are used in diagnosis of coronaviruses are mainly respiratory specimens, although the virus can be detected from other type of specimens like blood or stool, but upper and lower respiratory tract specimens are most widely used. These specimens are collected in special viral transport media and which contains lysing agent to lyse the virus. Now, depending on the temperature, the specimen can be stored or for a period of few days if refrigerated, to a long time, of course, if frozen at -70. The PCR assay that is used, that most widely used, starts with reverse transcription of the genome into a single-stranded DNA, and then a complementary strand DNA with DNA polymerase is produced. Then it's denatured into two single-stranded DNA, and primers are added, where primer annealing with also the addition of a fluorochrome probes to detect the DNA strands, and several cycles of annealing and polymerization take place with the detection of the fluorescent probe that is used. Now, there has been many advances made since the introduction of this method for diagnosis of SARS coronavirus 2. Specimens at the beginning, there was nasopharyngeal swab. Now, a gentle nasal swab or even oropharyngeal swabs can be utilized to diagnose coronaviruses or COVID-19. Now, the genes used vary from the different companies. 2 to 3 genes are utilized, usually one as screening and the other as confirmatory. However, the WHO recommends the use of 3 genes. They use the E gene to detect beta coronaviruses, then the N gene and the RNA-dependent RNA polymerase or the enzyme, the operating frame 1AB, is used as both as confirmatory genes. The next slide shows the different genes that are utilized in different parts of the world. Different companies, different parts of the world use different combinations of genes to detect, they make a diagnosis of coronavirus 2. Now, regarding the reliability of reverse transcriptase PCR, there is a chance to get, of course, false negative as well as false positive results. That's why it's very important to have quality control in place. And according to Dr. Robert Schmerling from Harvard Publishing, the reported rate of false negative is as low as 2% and as high as 37%, whereas the false positive rate is about 5%. Of course, timing, type of specimen, and the stage of disease are important in determining these, in affecting reliability of test. Regarding test results, tests are either negative or equivocal or indeterminate or inconclusive. These terms are used variably in different labs, or positive, and positive results should be reported immediately. Now, regarding the indeterminate or inconclusive or equivocal, retesting is recommended using new specimens, and the guidelines do not clearly differentiate between these terms, which are used in different labs, and the laboratory physician can decide the term to be used. Now, regarding interpretation of PCR results, if the positive control is positive and the negative control is negative, and the gene is detected within the CT or threshold cycle threshold value or the cutoff value, then this is a positive test for the gene that we look for. If no target gene detected or the CT value is higher than the cutoff, then this is negative for the gene. And all results of negative, if the negative control is positive and the positive control is negative, should be retested. Now, to more details, we have the different combinations. If the screening test is positive and the confirmatory test is positive, this is a diagnosis of COVID-19, positive test for COVID-19. And if the screening test is positive and the confirmatory test is negative, then this is negative for COVID-19. However, it should be here, we should look for other viruses. Beta coronaviruses could be the cause of a positive screening test. Now, if the screening test is negative and the confirmatory test is negative, this is negative for COVID-19. And if the screening test is negative and the confirmatory test is positive, we should retest or refer to a reference lab for additional testing. Of course, there are causes of false negative test, like inadequate specimen or quality of the test result should include all information regarding patient name, sex, age, etc., ward, and test order date, specimen type, etc., like any other lab result in reporting. Now, retesting may be recommended if it's a highly suspicious case of COVID-19. We can either retest if the specimen is not available, we can re-extract specimen, or we can obtain another specimen. In cases on some companies produce tests like the isothermal amplification incorporating the CRISP technology, this is a method that can give results within 30 minutes. It is used by some labs, or it may be used as a confirmatory test in equivocal cases. Two issues of importance in diagnosis of COVID-19 are safety and quality assurance. Safety is of paramount importance, as you know. We should use biosafety cabinet level 2. And here, the policy for diagnostic testing laboratory certified to perform high complex testing under the clinical laboratory guidelines. Authorization control is very important. That's why complete gear and PPEs should be on. Disinfectant procedures for surfaces for the lab is very important. Regarding quality assurance, when a new test, a new technician, validation is very important. For PCR system, each A nucleic acid amplification test sample should include internal control, as you know, and ideally a specimen collection control like human gene. Additional external controls are recommended for each test run. Laboratories that order their own primers and probes should carry out entry testing or validation looking for functionally and potential contaminants. Now, of importance is the external quality assessment. Labs should subscribe to external quality assurance in this regard. And I'm trying to finish within time. Thank you very much. Thank you, Tariq.
Thank you, Dr. Azmi. Thank you very much. And thank you for bringing the quality assurance topic and the sensitivity and the specificity of the tests. Actually, at the beginning of the pandemic, and because of many kits have been used in an urgent manner, the performance of the test were not very well identified. And now the situation is better. There are some validation steps, some regulatory authorities that are working on that, like, for example, WHO, which contain laboratory emergency using list, and the Foundation for Diagnostics find. So I think we're gonna have more discussion during the Q&A.
Yeah,
Thank
probably
you.
this.
Yeah.
There are very important issues in this regard. Yes.
Yes. Thank you, Dr. Azmi. And the next speaker, and we are happy to have with us Professor George Araj, Director of Clinical Microbiology Department of Pathology and Laboratory Medicine, American University of Beirut Medical Center. Professor George got his PhD in medical microbiology from the American University of Beirut. He is a diplomat of the American Board of Medical Microbiology since 1986, and he is a fellow of the American Academy of Microbiology since 2000. He's currently working as a professor and the director of clinical microbiology at the AUB Medical Center. His research interests are the development of tests related to the diagnosis of infectious diseases, specifically tuberculosis and brucellosis, and the characterization of antimicrobial resistance. His research studies culminated to over 200 publications spanning over a wide range of topics related to clinical microbiology and infectious diseases aspects. Dr. George, you are welcome, and the floor is yours.
Thank you, Dr. Tariq. Yes, just a second, let me set here. Okay, thank you, Dr. Tariq, and glad to be with you, dear colleagues, and hello to all the audience. I will be reviewing the antibody-related issues in terms of the immune response and how we can detect and try to evaluate. This is a view of AUB campus for Dr. Azmi, in case he didn't visit long time ago. And one would wonder if anybody has the desire to talk under the current circumstances in Lebanon, where you have a multifaceted, devastating, and protracted problems and saga, whether being explosions, being suffering, human suffering, being asking for, liberation of the corruption, and having the corona, and having the devaluation of the pound, and having the economic crisis. Really,
God with you, Dr. George. God with
Allah,
you.
God be with you, but we have to keep the resilience and proceed.
Yes, you have to.
So what we are going to do, what I'm going to do is that I'll address the general immune response aspect and infection related to concepts, COVID, then I come to that infectivity aspects, or incubation and duration, time of COVID antibody response, rapid antibody test, utility and significance. We'll talk about the persistence of and duration of COVID antibodies. We'll talk and address neutralization activity and immunity, and we'll try to go over the interpretation of antibody test results and try to conclude. How do we go with the immune system? The immune system comes with two major arms, the cell-mediated one and the humoral one, definitely, in addition to the other part of the regular immune macrophages and that monocytes, that innate immunity that you have over there. And this system really undergo an orchestration among the different cells in order to have an efficient encounter of any invader to the body, whether being antigenic determinant, pathogenic, viral, parasite, bacterial, etc. So this is a key kind of approach. The most important is the coordination. And even in COVID, I will just spell it out from now. It's not only the antibody which are important, though antibodies are the major protective parts or defenders in terms of the viral encounter, but definitely there are a lot of studies now talking about the cell-mediated part and the T cells involved there. Generally, in any infection, this is the classical format. You have the initiation when you are exposed to an antigen. You have the IgM first initiating, then it is followed by the IgG, and you have an anamnestic reactive by IgG. Now, does this apply in terms of the COVID? In COVID, there are reports that both IgG and IgM simultaneously are being developed at the same time. But others, you'll see how many percentage have been encountered from studies in relation to this. So what do you do in order to test these antibodies? Generally, you have different classes or generation. We have the first in relation to those classical one, agglutination, precipitation, neutralization, flocculation. Then we came more sophisticated, fluorescence, radioimmunoassay, counter-immunolatics, agglutination, coagglutination. And then we came to the third generation, like the ELISA, and fourth generation. It looks like the cephalosporins, third generation to fourth generation we have in terms of the serologic diagnosis. Most of what we do in relation to COVID, they are playing with ELISA and the membrane chromatography tests. So what does this formula mean? This is essentially the core concept of infection versus diseases. What it means, this is a disease, and what causes the disease is the number of the pathogens, their virulence, and this is where if they win over the immune system. So this is the major part where you can explain any infection in relation to disease or no disease. Number times virulence over immunity, whether you get it asymptomatic or symptomatic and that sort of stuff. What we are trying to do in relation to COVID is to get it asymptomatic, mild. And this essentially is in relation to the number. And this is essentially what are we trying to preach? Keep the distance and keep the mask. In order when you get a load, you get it mild one for your immunity to cope with. Now, let's talk about the COVID infectivity aspects. It was shown here, definitely more detailed was presented by Dr. Azmi. Now, what we are presenting here is the antigens. These are the different types of the antigens that, especially the spike proteins, nucleocapsid, are the ones with the receptor binding protein, are the ones that are being utilized to produce monoclonal antibodies in order to do antigen detection test or antibody detection test. So this is the basic form. And actually, there are differences in terms of their efficiency, in terms of detectability, which we'll be observing. Now, the basics. Do we know what are the infectious doses of the virus for COVID to infect humans? I really don't know. Is it 100 copies? Is it 1,000 copies? Is it 1,000,000 copies? This studies has been done in relation to other pathogens, like anthrax, we know. It is, for instance, 1,000. If you talk about Brucella, you can probably have 10 to 100. If you're talking about Salmonella, you're talking about millions. If you're talking about Shigella, you're talking about hundreds, okay? So still what we are talking about here, This is an area which has to be determined in relation to humans. What is the infectious dose? And this virus is really highly infectious to be so efficiently spreading around the world. And the virulence of it is also remains to be efficient and worldwide active at different levels. Now, this is what I'm trying to say here. In relation to the infectious dose, we don't know. And again, I put it here, wearing face mask is the idea of preventing or minimizing the infectious dose, so allowing the immune response to handle without major consequences. Now we come to the incubation period and duration of COVID infectivity. And this is essentially for molecular activity. How long do you have this? The incubation period, in terms of when you get the virus, in order to start manifesting symptoms, they say that it is within 5 days, but it ranges from 2 to 7 days. Now, how can the detectable virus level, the detectability of viral levels, this is where the PCR plays the role here. It is 2 to 3 days before the symptoms onset. It peaks probably around the 5 days, and it declines after 8 days. Definitely, after 8 days to 10 days, duration of positive had a prolonged for weeks can also, but mostly here it will be a non-complete virus. You are picking up a defective virus or parts of the virus. But the infectiousness, most of the studies is talking about, it doesn't exceed probably 10 days in relation to actual active infectiousness. But detectability of the virus versus the PCR, it could go for probably 80 days in relation to that. But this is not really a real virus that you are picking up. You're picking up part of the virus. Now, this is studies, I'm reporting here the studies done in cell culture. And this is where also it relates with the PCR activity. If you have the cyclic threshold over 35, there is no way that viral was recovered. The first week, positive yield in the first week of symptoms, no viable in specimen taken over 8 to 9 days. This is what studies are talking about. Culture positive rate decreases with rising PCR CTs. This is known. And samples can remain PCR positive over 20 days and more than weeks. In human respiratory samples, infectivity is around 10 days. 15 days, some studies mentioned, and even 20 days when we have in longest reported for competent virus infectivity. And mostly those will be kind when you have severe infection or you have people with immunocompromised. So this is the duration which we are talking about, and I explained it. And this is a diagrammatic presentation versus days, as I explained. So what plays a role? What is the thing which are involved there? You have the pathology of the immunity there and the track of the path of it. If you see here, when they delineated the T cells, the CD4 and the 8, and how long they persist in relation. And they went down to the humoral part, and they talk about the IgM and IgG and IgA. Definitely here, the IgM probably takes few weeks. Some studies say that, but others shorter time. And the IgG here, also the one which is prolonged, as you will see, and you will find in a different more studies that have revealed that. Now, infectious agents stimulate the immune response by both triggering mobilization of the T and B cells, and this is where the cell-mediated immune response is becoming and acquiring a lot of importance. Test can detect G, A, and M classes as well. For COVID exposure, the evolution and role of cell-mediated determined to expose remain unclear, but studies are being clarifying in relation to this. And the specific immunoglobulin were reported to be used as immune response indicator of viral exposure and can have a diagnostic value. So both. It's mainly the exposure that we have. So what do we have in lab diagnostic test? What I have in that, I just want to present this. This is, I wrote this article, review article, like we summarized to enlighten our community, the health community, and even the wider people around about testing for COVID-19, when you test, who you test, and what you test. And this, we published it, actually, I wrote it early this year. Maybe I was working it and finished from it probably in April. And it took some time to publish it by the Lebanese Medical Journal because we have a special issue that we put there in it. And we addressed the three arms: molecular, antigen, and antibody-based tests. This is a comprehensive paper if somebody is interested to look at it. And again, here it talks about what do we have in terms of the molecular, in terms of the antigen, how long they will persist. For here it's 21 days, they say, and for the antibody, which persists for a longer period of time after exposure or infection of this. The antigens used, as it was diagrammatically presented in the picture, you have the spike proteins, you have the nucleoproteins, you have recombinant antigens, and definitely these antigens have been selected in a way that to minimize the cross reaction with the normal type of coronavirus, which is normally encountered in winter seasons again. All right. So now in relation to test, what do we have in relation to test globally? You go to the FDA test and you find that there are 224 total number of antibody tests in the market. 72 number of tests should have no longer be offered. 193 tests in the market without FDA approval. Look, 6 approval which have emergency use utilization for this from the FDA, there are few. And this is what Dr. Azmi mentioned, and you have to validate your test and you have to have a reliable test before you produce your results. So we rely on what has been assessed and published, and it is much better because so many tests and many of them are being withdrawn can give you in an area of false positive and false negative and mislead the diagnosis and mislead the physicians. So what do we have in terms of cough antibody response in relation to this? Okay. The timing of antibody response, as we mentioned, when we have the infectivity of the virus going up to 8 days or 9 days, after that, you start building the antibodies. So the antibodies start being initiated or developed between 8 and 11 days, and definitely they should have it by 14 days, especially for that. And in relation to this, as I mentioned, when we have the classical immune response, IgM and then IgG, this study by Gu, he mentioned that IgM appears earlier than IgG in 27. There is a simultaneous appearance of IgG and IgM in 34% of the patient they tested. And IgG appears earlier than IgM in 39. This is confusing to the immunology conception that we have been trained and understand in relation to other infectious etiologies. So extensive ongoing research is a top priority for appropriate and accurate clarification of the serodiagnostic features and immune response of the COVID virus. It depends what test you use, what antigen you play with, and what you try timing, which you can test the individual. So what are different tests that we have? Test formats, there are 3 major test formats that are used: the immunochromatography, the ELISA, and the chemiluminescent. And this is rapid and not automated. These are more complex in terms of necessitating equipment and that sort of stuff. How reliable? Definitely they have reliability, which is FDA, and if it is approved, it should be sensitivity and specificity definitely over the 90%. This is an example of those rapid tests, and we use them in our lab. Now, utility and potential use of rapid tests. Now, you have an antibody, and what do you want to make of them? What can you use or utilize and benefit from those antibody? There is some assess that it can help you to assess the seroprevalence, contact tracing, surveillance, and tracking. in relation to the community nationwide. Then you can help, they are helpful to define the size and nature of the epidemic and guide lockdown, reopening, and integrating society. This is if really are used by the government at different levels. Yani. You need to have this not fragmentary work or approach to it. It has to be a comprehensive approach in that situation. Then the suggestion to both two types of tests or both methods. Yani you can use the PCR, definitely it has to be there. And you have to use this kind of antibody testing, which can give you a better value in relation to diagnosis and preparation to assessment. Important to keep in mind, I'm talking about the healthcare staff and the asymptomatic. This is definitely where you can have the molecular and as well as the antibody. And in relation to the healthcare staff, it needs really, you have to test in a hospital. You have to know what you are dealing with because many of the infections are asymptomatic and they can transmit infection. So if you can capture or you can say that he has an antibody, then you are under a more comfortable situation to say, well, I can do the cohorting strategy and remove suspected cases from here and here. Then the healthcare worker, definitely helpful to decide pertaining to return to work, deployment, assuming there is no, assuming there is a protective immunity. Now WHO and CDC, maybe they don't like this kind of idea, but they will change as they have been changing the recommendation all along. And then this is important, utilizing the antibody for convalescent identification from new recovered patients for convalescent plasma. And this is an important area where they are trying to do, especially based on quantitative testing. Now, definitely, though they are easy to perform those antibody tests, but it has to be definitely correlated with the clinical situation, and you cannot use them without having a good validation and establish important guidelines. Now we come to dispute areas. Persistence and duration of COVID antibodies. Some people, they say, well, this is 2 months or 1 month or 3 months or this thing. And other paper, they say it is up now so far. There are studies which shows it is going for months. And this is definitely the situation here. Antibody duration can persist. And they have done many results here. For instance, study from Iceland, it shows that 4 months. Persistent of active antibodies, if you look at them. And you come to talk about different antigens, for instance, anti-S1, you call receptor binding domain, or the nuclear. They try to see which one is persisting more or not more. But here in this situation, it looks that they have almost similar kind of persistence, whether you test this antibody or that, this antigen against this antigen or against that antigen. Another study from California. It is a persistent and a long time, up to 150 days. It is going there. And if you use, for instance, the S1 domain, if you take each patient, this was categorized in Greece, you will find that there is also a persistent for 100 days at least in relation to this. So I am really, I can say there is a good persistence of antibody. But I have to keep in mind that even, we have to think that even if you are re-exposed, you have a potentiation of your cells that can encounter this kind of infection, despite if you are persisting for longer period of time or not. Do you have neutralizing activity? Yes, I say definitely yes. And this is not definitely because I did the experiment, but when you research into the reliable, accurate data, definitely you will find that the first study which came out, which was very comforting, is the infection of rhesus monkeys, where they re-challenged it and it was protective. There are studies also from antibodies in relation to patients that has been infected and they couldn't be reinfected. In vitro studies showed real neutralization. So you have in vivo and you have in vitro. And the neutralization here, which they showed it accurately to be up to 3 months, but it could be more depending on what you have. So persistence of neutralization, this is an interesting publication.
Dr. George,
خلصت قربت يعني just 1 minute or 2 minutes max if you allow.
Thank you.
Now that the titer persistence of the neutralization, you have very high titers going on, and these are very effective and has been the neutralization. They tested them at 30 days and they became more even at 82 days. And some of them, they say after, depending on the severity of infection, how the neutralizing antibody can be used in relation to this. Okay, key factor, correlation with clinical information and combination of test results that you have. So when you have to have the results to utilize it for clinical use, definitely you have to give some sort of an explanation. What does it mean when you have a seropositive or a seronegative results? And there are different criteria that we are producing even with the report to the patient when we test him. All right, is that good, Dr. Tariq? You like this conclusion?
Thank you so much. Thank you, Doctor.
Okay. Thank you. We'll probably talk more about the discussion, which I like more.
Yes, actually, there are many unanswered questions on the immune response, the neutralization activity of produced antibodies, the sensitivity and specificity, or actually performance of rapid diagnostic tests, and in which context we can use this test and in which we cannot use. Hopefully we can discuss that during the Q&A session. So please join me to welcome Dr. Erin Sorrell from the Center for Global Health and Science and Security, Assistant Professor, Department of Microbiology and Immunology, Georgetown University. Dr. Sorrell received her undergraduate degree in animal science from Cornell University and got her MSc and PhD in animal science and molecular biology from the University of Maryland. She was a postdoctoral fellow both at Erasmus Medical Center in the Netherlands and the University of Maryland. Dr. Erin works as an assistant professor in the Department of Microbiology and Immunology at Georgetown University, as well as a member of the Center for Global Health Science and Security. She works with partners across the US government, international organizations, and ministries around the world to support health system strengthening and laboratory capacity building for disease detection, reporting, risk assessment, and response. Dr. Erin will talk to us about the global situation in testing challenges and some key factors related to the global situation and what is better to choose when testing, mass testing, and all these issues. Dr. Erin, please.
Thank you, Dr. Tariq, and thank you to the entire MPNet team and to my esteemed colleagues I've had the pleasure to present with today. Good afternoon, everyone. So as Dr. Tariq mentioned, I'm going to give just a very brief overview talking about some of the testing situations and challenges from a global perspective. If we think about just in general, the role of diagnostic and public health laboratories, they are essential, not only in providing early warning of disease outbreaks at the local and national, but also at the regional level. And what we found over the course of a number of years of analyzing public health networks is that tiered and integrated lab networks really provide capacities that are needed to detect, confirm priority diseases in a timely and efficient and cost-effective manner at all levels of the health system. And achieving accurate, reliable, timely, and safe diagnostics and confirmatory testing really helps collaboration and is required in terms of thinking about laboratory quality management at all levels. And so if we think about the role of sentinel labs as recognizing, ruling out, and referring, reference labs looking at confirmation testing, and then our national labs doing definitive characterization, there are steps for all in this process. So in an ideal situation, and particularly speaking to this ongoing pandemic that we're facing with SARS-CoV-2, in an ideal world, we have processes for surveillance, for testing, treatment, tracing, and quarantine, depending on the disease, but in this case specifically with COVID-19, important aspects, and then implementing infection prevention control, social distancing when necessary, and vaccinations when possible. Throughout this process, it's really important to think about communication, right? Both risk communication to the public as information changes, as technologies advance, as well as communication if we think about the various sectors involved in this entire process of what we would consider outbreak management and response. And I think everyone here can agree testing is a must, right? Testing is what allows us to very simply identify the sick and separate them from the well. And without testing, we don't have data. We don't have information that can inform our response, thinking about both containment and mitigation. So there have been a number of interim guidance on testing. WHO, I think the most recent was earlier this month, looking at diagnostic testing for SARS-CoV-2. They have a number of resources on their website. One of the things that has been challenging at a global perspective is talking about what is the absolute key number of tests that should be held or should be run on a daily, weekly, monthly basis for each country, for each region, for each state. And what's challenging is the positivity rates that have been reported. And so if we think about having a high positivity rate, it suggests that there's most likely higher transmission that we're capturing, and there are individuals in the community who are infected, who haven't been tested, who haven't been captured, and therefore we run the risk of transmission in the community. WHO back in May had recommended that the percent positive rate be below 5% for any government looking at reopening for at least 2 weeks before reopening. And we can see in the US as a perfect example that when those recommendations aren't followed, we have very high community rates of infection. A low percentage positive rate would indicate the level of coronavirus transmission relative to the amount of testing that occurs at that time is low at that time. And that's usually due to good education advocacy and communities practicing social distancing, and government entities and public health laboratories doing aggressive testing and isolation of patients. So when we have high positivity rates, 2 ways that we can lower them is to reduce the amount of coronavirus transmission or increase the number of people who get tested. But there's a trick there, because we can increase the number of people who get tested, but without understanding where those outbreaks are coming from and tracking those outbreaks, we aren't really understanding where the risk of transmission occurs. So testing promotes the understanding of rates of transmission and the extent of incidence, but we have to think about aligning increased testing to tracking and documenting where cases are coming from. And this is a schematic that was updated earlier this week. And it's our World in Data. The website is listed on the slide, looking at, on average, the daily tests run versus the daily new confirmed cases per million people. What you can see on the y-axis is the daily tests per million, with the x-axis being the daily confirmed cases. And what this just shows in a kind of a snapshot approach is that we can see that some countries are doing either tens or 100 fewer tests than others with similar number of cases. And so there's a discrepancy in terms of understanding the actual caseload, where these cases are occurring. And there's a number of reasons why testing could be restricted in some countries versus others. But this just gives a snapshot of, from a regional perspective, where some countries are doing better than others in terms of total number of testing. This is a very busy slide, but this is a slide that is pulled together. Johns Hopkins University does a fantastic job of looking at tracking a number of different data on coronavirus. And this is looking at the current testing capacity in comparison of positivity rates and tests. And what you can see on the red line here is that 5% limit, which WHO recommends, and the number of countries who are below or above that 5% positivity rate. This graph shows a 7-day moving average between countries' positivity and daily tests per capita. One of the challenges here is that some countries report the number of total tests, where other countries report the number of total people tested, and one person could be tested multiple times. So it's very important when we look at collating data on a global scale that we're doing it in a way that the data matches. The size of the circles here indicate the epidemic in each location. So ideally, each country or each location would have a small circle and it would be at or below that 5% line. And this is something that gets updated on a weekly basis through the Hopkins tracker, and just shows that we're having challenges as a global community in terms of our positivity rates and really understanding where outbreaks are occurring. This is just a snapshot from the MENA region, looking at the number of positive cases versus the numbers of tests per 100,000 populations. Again, this is a 7-day moving average. And I think what's important and something that we've seen in the literature, both in terms of peer-reviewed publications and a number of news outlets, as we look at testing capacities, is that in order to effectively respond to this pandemic, we can't have a general number for the entire population. We need to think about how testing programs can be scaled to the size of the epidemic in a country or in a region, not the size of the population. Again, I think the US is a perfect example. We are running, I think, the largest number of tests, but we still don't have this under control. So we need to rethink our testing strategy. So in terms of challenges, and there are many, and this is just an opportunity to capture some of them, we have to move faster than the virus. If we aren't able to do that, we're not going to be able to contain transmission. We've seen all the way since probably February this year, and this continues today, that we've had disrupted supply chains, both for test kits, supplies, consumables, and reagents, and this can continue to be a problem. And so how do we think about this from a global perspective? We have high demand for test results, and we have delays in test results. And from a control perspective, that is quite challenging when we think about trying to identify, trace, and mitigate community transmission. It's a very challenging situation in terms of both financial and human resources. A number of nations are constrained in their ability to redirect and reprioritize. There can be a lack of reliable transportation networks and routes for laboratory networks, both at the local and the subnational level, and that can unevenly put pressure at the national level for a number of tests. Challenges with integrated data management and reporting systems. We in the US have had a number of challenges with reporting structures and requirements changing and changing very quickly, and causing trouble really at the clinical level for reporting data and balancing that with patient care. As my colleagues have talked about, there are a number of tests with variable quality, and they yield very different results. And so understanding which test is used and how to interpret that data is critical. Challenges also in terms of repurposing lab facilities for COVID-19 testing, and that then redirecting attention from key priority diseases in a nation to the pandemic can alter other public health priorities and public health outcomes from a diagnostic and clinical perspective. In terms of possible solutions, and I think there are a number of success stories, regional approaches, in terms of just kind of some generic situations, we've seen a number of successes in terms of pooling samples for PCR testing. Integrating rapid antigen tests for surveillance, thinking about how to add that as an additive, not a replacement, in surveillance and diagnostic testing. I mentioned before, scaling testing programs to the size of a state's epidemic and not the size of a population, I think, is critical. And then some examples of some, I think, success stories. are the Integrated Diagnostic Consortium and African Society for Laboratory Medicine resources and online training, as well as I think this MFINET webinar series is a fantastic resource for individuals to get access to information and lessons learned. Africa CDC led task force for coronavirus pandemic and response increased capacity testing from 2 to 43 countries between February and April, which I think is huge. And MFINET promoting the role of FETPs and rapid response teams in response to COVID. And there's many, many others, but I just wanted to capture a few for discussion today. And that's it on my end. I'll wrap up and happy to look forward to discussion. Thank you.
Thank you, Dr. Erin. And coming back to the challenges, actually, these challenges showed how the world is vulnerable and it's not ready for maybe smaller than this outbreak, not for a pandemic. So hopefully there will be many lessons, and we'll look for future to develop maybe more task force, more space, more equipment, more resources to fight against maybe the next outbreak or the SARS-CoV-3 or 4 maybe. So thank you so much. We are going to the Q&A session, and I have a question for Dr. Azmi. Virulence of the virus change over the pandemic span. You know, we have heard a lot about the change of virulence or the many subtypes of the virus and different virulence specifications or characteristics of the virus. So can you elaborate on that, Dr. Azmi, please?
Yeah. Coronaviruses, as I said, have more than one mechanism of genetic change, which can lead to increased or decreased virulence. One is mutation, and there is an excellent example. In 1980, transmissible gastroenteritis virus, coronavirus, that used to infect pigs, underwent a mutation with the loss of about 1/4 of its genome, resulting in a new virus, which is a respiratory virus that killed tens of thousands of pigs in Europe. And that is a classical example of a major change. The other is recombination, which is the discontinuous transcription or transcriptase jumping. The transcriptase of the virus, the RNA-dependent RNA polymerase, can can jump from the template while copying the genome to another, if the cell has another virus, to another RNA, and continue transcription or polymerization of RNA, which leads to the emergence of a new virus. So mutation as well as discontinuous transcription are sources of genetic changes. This can happen. During this pandemic in particular, one famous mutation is the D614G, which is widespread all over the world. It has been said that this has led to increased transmission or spread of the virus, but decreased virulence. But it's a matter of controversy. Many people do not believe that it underwent a decreased virulence. But there is an observation, clinical observation, that the mortality was very high from March up till the end of April. Then we witnessed a sort of decrease in mortality. Now, those who recovered, 24 million, have a mortality rate of 4%. That's questionable. There are many reports that argue on this. But now there are about 7 million patients. 1% of them are critical. About 60,000 are in critical or severe condition. Only 1%, which points or tells that virulence has decreased. That need to be substantiated by any molecular evidence.
Thank you, Dr. Azmi. The question for Dr. George, how reliable are the PCR results when the sample is collected and left for several days before testing? Even it was according to the guidelines, it could be freezed. And if the positive result affected by the time passing from the collecting the sample, since the nature of the virus is not that clear.
I think this is supposed to be directed to Dr. Azmi, because
Yes,
he's the guy who talked about the molecular part.
Yeah, I said there was a table in the presentation which shows that the conditions of temperature, storage conditions, and the time. It details for all specimens that are used, whether respiratory, stool, blood, etc. In general, it's few days if refrigerated, 2 to 5 days maximum, but it's long time if frozen. That's in most of it is in the presentation. It was one of the tables in the presentation.
Yeah, thank you, Dr. Azmi. Thank you, Dr. George. Actually, I think we don't need the results after several days. We will lose the contacts. We will lose everything.
Yeah.
Even if we have a positive result, I think if the specimen is frozen, we can get some result from it. But
sometimes if you have an equivocal or indeterminate result, you need to repeat. Yes. So if you have the specimen, you can go back and extract the RNA and run the test again. So that's why the 2 or a few days, it can be useful.
Yeah. So a question for Dr. Eren. Why WHO did not recommend diagnostic based on epi-linked classic symptoms plus contact with confirmed case, considering the high cost of the test, and many developing countries are unable to afford 4 million of tests. And I can add here for how long we are going to test and afford such millions for testing. Dr.
I tell you the question, I myself did not understand. I don't know if Erin did understand it. I don't understand. Can you repeat and understand the core of it? Because there was some...
So in order to keep, it's a money-wise question, in order to keep money and not to test money and to afford many tests, so we go and recommend diagnosis. Why WHO did not recommend that based on epi-linked, like classical symptoms plus contact with confirmed case only, because we cannot afford such a huge number of tests.
Yeah, it's a challenge. It's an important question in terms of thinking about if you have a confirmed case and you then have identified contacts who present clinically, could you then say these are individuals that could just isolate at home, social distance for 14 days instead of getting tested because of not only delays in time it takes to test, but the cost associated with testing. I think that that's something that can be done in practice, particularly when resources are constrained. What it requires is identification of those contacts in an effective and timely manner, and making sure that those contacts understand the role and the importance they play in isolating at home, and making sure they have a home opportunity and environment where they're able to do so and not put their own family members at risk. The PCR tests are quite expensive. They are the gold standard diagnostic. As Professor George and Professor Azmi have mentioned, they're critical in documenting cases, right? For WHO, their requirement in terms of reporting official cases is a confirmed case by diagnostic testing. To my understanding, that has not changed. So in order to think about how to report caseloads with contact tracing and isolation and clinical confirmation, that's something I think that is up for consideration, but has not been approved by WHO. I hope I addressed the question.
If I may, if I may add, in outbreaks like RSV or so in hospitals, you test at the beginning, then you stop testing and you make a clinical diagnosis. And in the States, I mean, Dr. Kat and Professor Osterholm from Minnesota, I believe, they were discussing the issue of, rather than testing everybody, is to do serological testing of a representative sample and then to draw out policies or regarding the outbreak. These are, and these issues are really being under discussion.
Yeah, and if I could add to that,
yeah,
add to that, I think when we're managing the outbreak, our rapid diagnostic tests, our antigen tests that are very inexpensive and very quick can help with identifying individuals who are positive, right? It's not as sensitive or specific as a PCR test, but it is a very helpful tool for point of care diagnostics at a clinic, at a school, at a workplace to say, okay, you come in today, you are negative, you can continue to work. If the rapid antigen test indicates a positive, you go home and you isolate for 14 days. And I think that is something that we will see. I know WHO has approved at least one, if not two different rapid antigen tests that we can now bring forward and use in a much more effective manner to manage cases and to manage community transmission. And I think that's a positive.
Yeah, thank you. Thank you, Erin. Thank you, Dr. Azmi. We have a question for Dr. George about monoclonal antibodies, whether there are information if they are providing effective immune response to COVID-19.
No, what I mentioned about the monoclonal antibody is to be utilized in terms of diagnostic, really. But in relation to protection to COVID-19, you have multi-players in relation to encountering the infection when you are exposed to the virus. Definitely, you will have the primary one will be there because you are fading with the IgM within like a couple of weeks, and 3 weeks. The IgG will shoulder the responsibility to defend. This is the main defender to have the specific IgG. And this is not a monoclonal IgG from the body. You don't have that monoclonal IgG from the body. Monoclonal you can create outside the body. But it is the interplay of the immune system, the B cells and the T cells. I don't have to disregard the T cells. I think you have memory cells that they can be kind of geared up and mobilized in terms of any encounter to be kind of coming forth to defend against the virus. So this is the situation. And just to clarify to the speaker, to about the question, monoclonal antibody, you develop them primarily in vitro.
Yeah, if I may add, Dr. George mentioned that some individuals produce IgG before IgM first. That's an important issue to point. It has been shown that individuals who donated blood before the outbreak have antibodies to SARS coronavirus 2. It is explained on the basis that they were infected with other coronaviruses like OC43 or 229E or others, HKL, these, the non-respiratory severe viruses. So as you know, the antigenic epitope is just few amino acids, 46 amino acids. They look similar in different coronaviruses. So when they get corona, this is an anaplastic response. This is secondary immune response to because sometimes the immune system does not distinguish between these minor differences, which results in a secondary response to the new virus as a consequence of exposure to an old similar virus.
Well, that's an interesting explanation to the Chinese study, because when I mentioned about it, I couldn't comprehend it. And if you think that what you are trying to say also, there is a major cross-reaction. And according to the tests which are being put forth in the market, maybe the cross-reaction does not exceed 1 to 2% if with the other viruses that you have there. So we should be kind of comforted when we are using those antibody detection tests in relation to this. But well, I appreciate your explanation about blood donation or exposure or that sort of thing. Thank you.
Thank you, Dr. Azmi, Dr. George. So we have a question for Dr. Azmi also in terms of long positivity of the virus presence in the sample. Sometimes we test for after maybe 1 month, 2 months. So what do you think about the infectiousness here and infectivity of the virus, despite the fact that patient don't have any symptoms and it was like he was recovered?
Yeah, I agree with Dr. George that infectivity is lost within 2 weeks. And those are, I mentioned that there are defective interfering particles that are produced. These are not viruses, they are not non-infectious. And sometimes RNA, just RNA segments adhere there and they remain for a period of time. PCR was positive 63 days after illness in some cases. So this is not the virus for sure. These are defective particles interfering with whatsoever, but this is not infectious virus. Infectivity usually of individual is lost after 3 days of clinical symptoms are over. In most of the cases, that's those individuals are not infectious.
To comfort those that they face this kind of situation, I think they have to test with the antibody as well. And this will give you more comfortable content that exactly what Dr. Azmi and what I noted earlier is that you are playing with parts. It's not the whole missile which you are catching. You're catching fragmented parts, and they have nothing to do with any infectious aspect to the people around you or that. We face this practically with people whom they have quarantined for months based on this false positive PCR persistence detection. And they were asymptomatic, staying in quarantine, playing cards and doing all this activity. And they are just, because PCR, they did not understand there at that time. And definitely this antibody issue that you put it together in such a situation will be of great help to you to decide.
Maybe Dr. Allen can comment. I believe in communities with low level of this virus, the positive predictive value of the PCR is very low. It becomes low. That's another point.
Yes, exactly.
Yeah. Thank you, Dr. Azmi, Dr. George. So question to Dr. Erin. As we know, testing should use the risk-based approach, as the goal is to identify those asymptomatic or pre-asymptomatic people who were exposed to a case. So is it correct to say that those people with symptoms could not be tested as they have the symptoms, and that concentration should be on testing those exposed, thus screening the contact through testing, while the random testing and voluntary testing centers for population at large?
It's a challenging question because of just the capacity in terms of the number of tests and the time it takes to test everyone. I think one of the biggest challenges with this virus, with SARS-CoV-2, is that, as I believe Professor Azmi mentioned, the time when you present clinically, 3 days, 4 days before that, you are infectious and you are transmitting virus, right? So your incubation period comes before your clinical symptoms. And so trying to trace and track people that you interacted with 4 days, 5 days before you feel ill can be very hard for people to remember who they interacted with, who they were with. I think one of the balances in terms of thinking about workload in a laboratory system for testing of all those individuals is to test those that are clinically presenting. And I would love to hear from Professor George and Professor Azmi as well, but to test those that are clinically presenting, and then to use something like the rapid antigen test for their contacts. That would be a very quick way to understand if those individuals have antigen present, and they should then be confirmed through PCR, or they could then be isolating at home for 14 days. In order to do that, I think that's a much quicker way, a more responsive way to be able to try to contain spread than trying to do the PCR for all of those individuals. There's an estimate that for every infected person, you should be testing at up to 10 contacts. That could only grow in time, and that would be challenging from a diagnostic perspective. So I think using those rapid diagnostic tests for the contacts is a quick and easy way to rule out who may be at most risk of infection.
Yeah, I agree. And it's also suitable for healthcare workers. And the rapid test is one of the tests that is recommended for healthcare workers as well as for those who asymptomatic individuals. But regarding the number of tests, I know that it's recommended to test 10 to 30 for each positive individual. Do we have a number per 100 or per 1 million individual? Because when you review countries, it ranges from 0.2 per 1,000 to 9 or 10 per 1,000. So that area is still sort of vague.
Yeah. Thank you, Erin. Thank you, Dr. Azmi. We have a question also to Dr. Azmi for about the winter and the upcoming flu season. And as you know, we have, in addition to the influenza, other respiratory virus, in addition to the COVID. So what is your recommendation maybe for like testing, diagnosing? This will have a huge burden on the, especially financial and human resources also.
And I know this has been mentioned all the time, and the season will have a second wave or severe. The one issue is that the prophylactic measures that are used for COVID are the same for others. So they should work, and we should not be in a very bad situation or worse situation. The other issue, it's recommended for all individuals to take the influenza vaccine. And that's my recommendation. I don't know. There is now a test that multiplex PCR that can diagnose all together, all viruses. And there is one issue. In viral infections, there is a phenomenon known as viral interference. A cell that's infected with one virus usually is resistant to infection with another virus. This can take place. An co-infection can take place. But the interference has been observed, and that's why the name interferon. One of the mechanisms sharing the same receptor, occupying the sites for replication of viruses and production of interferon. So sometimes it works for the benefit of the patient. The infection with one virus may prevent the infection with the other at the same time. He may be infected at a later time. So I don't think that it would be that bad season. I don't know, but I'm optimistic with regard. I feel that what we are taking of measures now will act to prevent other infections as well.
Can I interfere?
Yes.
Definitely, Anna, with the season, definitely you should have 2 tests. And I'm going to go with the antigen detection test for the COVID, which Dr. Erin mentioned. And if this is an FDA approved that is circulated and available, definitely I'll procure. And simultaneously, this will be definitely, should not be an expensive test. If you are talking about immunochromatography, we are talking about a rapid test.
Yeah.
If I have these rapid tests together with the COVID rapid test and the influenza test, then definitely the doctor would like to know which virus is causing the infection.
Yeah.
Before we went live, I was just chatting with Dr. Tariq and Dr. Erin if there would be some sort of a device that they will have the multiple lanes to put corona, influenza, and even RSV. If you can have this, I don't know, you mentioned something. I mean, do you know of somebody who's manufacturing this? I haven't seen that.
Is available. Multiplex PCR is available already.
No, Johnny, I'm not talking about multiplex PCR. I'm talking about immunochromatography, which is very cheap and can be utilized if somebody produces these devices, put 3 lanes one lane, because it's easy. You have separate lanes. One lane for to pick up the influenza virus, one lane to pick up the respiratory syncytial virus, and one lane to pick up the COVID virus. I don't think it should be difficult, since you are doing IgG detection and IgM detection on the same kind of device. It has to be just, I wish I have the facility here to do it. I would have made money.
Lateral flow, yeah, you can. That's
Thank you, Dr. George, Dr. Azmi. I think I will have the last question for Dr. George. In terms of positive predictive value and negative predictive value, and if you want to have a combination of good tests where we make sure that we have good quality results and we don't miss any cases. So can you just elaborate on that and how they are affected by the performance of the test?
Definitely, positive or negative predictive values are part of the overall assessment of the devices before they are put in the market. And when we are talking about, I mentioned the FDA is not would not approve anybody with below 93 to 99% sensitivity and specificity in this regard. The problem here is, when do you test? This is the more important than just trying to say, well, the devices are reliable devices, and I've been using them. I've been trying them, but I compare them with PCR. I compare them with duration. And this is what we have to keep in mind in order to have an appropriate interpretation for this. I think these tests, definitely the immunochromatography test, the ones which they have received the FDA approval, I can comfortably say about that.
Yeah.
And I incorporated this some time ago in our lab, and we are doing it. And even I compared a couple of them, there are differences in terms of performance for that.
Thank you, Dr. George. So please allow me to thank you for your presence with us, for the informative presentations. Your Excellency, Professor Azmi, Professor George, Dr. Erin, thank you. And thank you for all participants. And for those questions that we have not answered, we will share with you detailed answers. After a while, we will prepare a report and share it with you with the detailed answers of unanswered questions. So thank you, wish you a nice day ahead, nice evening, and I hope to meet you again in our future webinars.
Thank you, Dr. Tariq. Thank you, colleagues, for the presentation. And thank you, audience, for everything there, for your tolerance.
Thank you so much.
All the best.
Thank you.
Bye.
Thank you. Bye-bye. Bye-bye.